The UWorld Global Lecture Series presents 4 lectures and panel discussions on the topic of global health, featuring faculty from disciplines across the University of Washington campus. This series, A Just Cause, Bringing Healthcare to All, is presented by the University of Washington Office of Global Affairs, in partnership with the UW Alumni Association. Video production was made possible through generous funding from the University of Washington Department of Global Health, with additional funding from College of Arts and Sciences, Mark Lindenberg Center for Humanitarian Action, International Development, and Global Citizenship, and the University of Washington. In this panel discussion, Fairness and Factions in Health, faculty examine how issues of access, culture, trade, finance, and regulation affect healthcare to world citizens.
Good evening. I'm Susan Jeffords. I'm Vice Provost for Global Affairs at the University of Washington, and I'm very happy to welcome you to this series. One of the key goals for the newly created Office of Global Affairs is to build bridges between different parts of the UW's 3 campuses, as well as between the University of Washington and our many partners in the state of Washington, the Pacific Northwest, and the world who care about the same issues about which we care so deeply. It is, after all, only through such partnerships that we can begin to address the many pressing challenges that face the world today. I'm particularly delighted this evening to be able to introduce our moderator tonight, Congressman Jim McDermott. As a physician, Representative McDermott is especially interested in healthcare issues. His work in this area results in what we are all trying to do, positively affect the quality of lives of people all around the world. So it gives me great pleasure, and I hope you will join me in giving a very warm welcome to Jim McDermott.
Thank you very much, Susan. I consider it really a high honor to be helping kick off this series. The University of Washington, as some of you may not really realize, is a really remarkable university. I received a notification recently that a copy of Mountains Beyond Mountains was being sent to all the freshmen coming in this year as their summer reading assignment. And it was also being given to the faculty. And I thought to myself, this has got to kick off in the minds of an awful lot of people this whole issue of what we do about global health. One of my roles in Congress is to serve as the ranking member on the Human Resources Committee. We deal with America's most vulnerable families. You learn fast that abused and neglected kids are innocent victims of circumstances beyond their control. They deserve the same life, the same care, and opportunities we provide for our own children, but they don't get it unless we intercede on their behalf. And the same is true worldwide. Now, rather than me talk longer, I want to get to the panel because they actually know more than I do. First, we will hear from Karina Walters. She's the William B. and Ruth Gerberding Endowed Professor in the School of Social Work. She's also an enrolled member of the Choctaw Nation. Rachel Chapman is an assistant professor in the Department of Anthropology in the School of the College of Arts and Sciences. Angela Godoy is an assistant professor at the Jackson School of International Studies and the Law, Societies, and Justice program. Both are in arts and sciences. Beth Riven is a medical doctor who is also a research associate professor in the School of Law. She's also vice president for Uplift International. We can read more about these speakers in this series on the web at www.uwalum.com. Let's begin with Karina.
Thank you, Mr. McDermott. Halito, good evening. It's a real honor and privilege to be here before you this evening. I'd like to begin with paying respect to the traditional owners of this land, the Duwamish peoples. And it's important in our traditions to always acknowledge the land that we stand on and the ancestors who are here with us today. And I'd also like to, in light of that, I'd like to acknowledge my grandfather. My grandfather used to tell me stories about the Trail of Tears and how my ancestors survived that. And what he taught me through those stories was the importance of resilience and strength and the importance of indigenous knowledge and wisdom, But actually what he also taught me, and this is the roots of what I do today, is how important historical context and culture is a part of our contemporary experience still today. I'd like to start a little bit with a little bit of background on global health disparities for Indigenous people. And although the data is sparse because it's not consistent across countries, there are some patterns that are worth noting. And first is that there's a pervasive pattern of health disparities, unequal burden of chronic illnesses, disproportionate levels of mortality and morbidity for behavioral health conditions such as HIV, cardiovascular disease, diabetes. And currently we're seeing really escalating rates of chronic disease states, respiratory and reproductive health problems, and premature mortality related to chronic diseases. One of the major factors associated with these poor health outcomes, so basically across the world, Indigenous communities bear the burden of poor health environments and then ultimately poor health outcomes. So we're dealing with disproportionate exposure to structural inequalities, environmental toxins, high levels of poverty and socioeconomic deprivation, and poor access to healthcare services. Now, it's not surprising that we see these patterns worldwide. And it's certainly due in large part to similar legacies of colonial circumstances, suppression of cultural practices, and dislocation or displacement from land bases and traditional ownership over health processes for our communities. That has been empirically linked initially to health behaviors, and we'll talk a little bit about that more in a moment. I'm going to talk more about the historical and intergenerational trauma and how that carries on today. Just a quick glimpse of US-based populations. We have about 4.1 million American Indians in the United States, or approximately about 1.5% of the total US population. The majority of our communities now live in urban settings, with nearly 65% of Native people residing in urban areas. Despite urbanization, we still have the highest rates of poor health as well as poverty and poor health coverage. So this economic vulnerability and ill health make Indigenous peoples even more vulnerable to poor diet and weakening immune systems and other things that are related to chronic disease states. This is just a quick little slide to kind of give you a visual of health disparities in terms of infant mortality across the globe. And these are, the smaller bars are the general populations, the larger bars are the disproportionate levels of infant mortality across comparing different tribes within each of these countries. And you can see that there's disproportionate infant mortality in wealthier countries. And of course, the people who are hit hardest are those who are living in poor countries. But the other piece about the slide that I want to highlight is the information for example, the Peru, the farthest line there. That's based on a very small group of people that normally would not be captured in large health data. And they would be literally rendered invisible because their numbers are so small. And so what we're seeing is the proportionate numbers is really what matters, not the total numbers in terms of the potential devastating impact on our communities. So people who are demographically small in size tend to be really overlooked with respect to health data and health policy implications. I'm going to illustrate with American Indians here in this country and Alaska Natives in terms of HIV. If you look at our total numbers, it looks like we are not that bad off compared to the total population. As you can see, we have the lowest bar there in terms of number of AIDS cases through December of 2003. However, if you look in proportion to our population, we're ranked third. Now, how many of you have ever heard about that in terms of the HIV data that's reported out there in terms of national trends? You usually don't hear a thing about American Indians or Alaska Natives. This invisibility is literally rendering us even in greater danger for health problems. We've had the fastest rate of growth compared to any other ethnic group through the 90s in terms of AIDS diagnoses. Surgeon General Satcher had said that he thinks that maybe Native people may account for 6% of the newly diagnosed HIV cases. That's in par with some small countries in Africa. In some of our own research, we started looking at trying to get an idea of prevalence. Now, the first top four are not based on probability samples, but the last two are based on samples where we did do some more where we think we have some representative numbers. And the Honor Project has to do with sexual minority American Indians and Alaska Natives. And I just have to say thank you to Jim McDermott, because he helped keep that grant alive when it was being attacked by Toomey. The other issue that we're faced is, even though we have higher rates of chronic diseases and infections, we also have higher survival rates, which is a major issue. The issue in terms of HIV surveillance data that parallels international health data is that we have huge problems with underreporting for indigenous health. We lack national and international standards for health data that is inclusive of indigenous populations. And currently, many of our actual surveillance systems don't even include American Indians or Alaska Natives or tribal-specific groups in any of that data. And there's an over-reliance on total number of cases as opposed to the proportionality issue that I addressed earlier. Our current work is now extending into looking at, what are some of the reasons for these health disparities, the etiologies. And this is based on indigenous understandings and worldviews and experiences with respect to traumatic stressors that people endure. And I'm going to give you a couple of highlights of what our communities talk about and what we mean by traumatic stressors and how they impact our health risk behaviors. This is an important piece because even when the research is showing that even when Native people improve their physical activity levels and other kinds of behavioral activities that would suggest better health, health disparities persist. So what we're thinking is, what are some of those causes? And now we're starting to look at the impact of trauma on some of our wellness outcomes. So traumatic stressors, the historical context, a little bit of the background here. A lot of people wonder why we have poor access to health care when we indeed do have opportunities for access. Well, there's a long history of actually maltreatment here in the United States with American Indians in healthcare systems. So in our communities, we talk about this being historical trauma or the historical trauma event. And these are the events that target communities, that systematically target communities, and it's believed in our communities that this trauma is still held personally and can be transmitted over generations. So I'll give you an example of what I mean by what those events look like. There was a period we call the boarding school period, where Native children were forcibly removed from Native families and placed into boarding schools. How many of you saw a rabbit-proof fence? Okay. Well, something like that happened here in the United States. That was with transracial adoptions. A similar process happened here with removal to boarding schools. These kids were removed to literally assimilate them into non-indigenous ways of being. So here's an example of a young Navajo man who arrived the first day at Carlisle Indian School, and this is him 3 months later. Now, why are these major issues for our communities? Well, first, these children were removed from their parents, placed in large-scale boarding schools where they didn't have access to traditional understandings of gender, sexuality, sexual expression. They were also exposed to high rates of child abuse and physical abuse. So now you're seeing the connection to sexual risk behaviors possibly for HIV. And then the other issue, so we have historical trauma, then we have contemporary traumas such as microaggressions. And those are those everyday experiences of being stereotyped and mistreated. And the reason why these are major factors our communities are talking about is because it's not just the single event traumas that are a big deal for us. That has devastating health consequences, but it's those everyday hassles, those chronic traumas that actually may have worse health effects on us over the long run. So we're starting to explore what do those things look like. So the objectification of us, we're stereotyped in the media, being surrounded with images like this all the time, it really just gets very tiring. Miss Universe. And what this does is it renders us invisible. It cartoonizes us. We cease to be real anymore. And that again, that's also reflected in being ignored in the health data. And the data has shown that discrimination has been related to increased stress and depression. Now you layer on top of that high levels of violent assaults. Native women, for example, the rate for Native women is almost 50% higher than that reported by African American males. And again, these are statistics that people don't usually hear about. And just to give you a little highlight of that, women, one, in the first study are Native women. Women, two, are sexual minority Native women. And so either way you look at this, these are very high rates of abuse and trauma that these women are enduring in some of our research. And so we've also found initially that historical trauma is related to poor health outcomes, mental health outcomes. And then I want to highlight some of the priority areas based on some of this preliminary work that we're doing that we would like you to focus on. The first is the issue of surveillance in terms of health policy. We really need to create a national standard for health reporting for use by country, state and local health departments. We need to require national and international health studies to categorize by indigenous statuses and tribal identities. In terms of research, we need more longitudinal research to really understand what are these pathways between trauma and wellness outcomes. Not everyone who's exposed to trauma does poorly. So one of the major questions that we ask is who's doing well and why, and how can we build programs around the strengths of our communities? Treatment and intervention, again, the importance of doing culturally based interventions that are based on our indigenous worldviews and ensuring that that is at the forefront. Some of the interventions that are imported into our communities are simply irrelevant and in some cases harmful. So it's important that we address that issue. And then finally, I wanted to talk a little bit about the incorporation of indigenous knowledge and the importance of that. Native people are the traditional owners of this land, and because of that, we have a traditional relationship to medicines and plants in the land here, all over the globe. And some of the health policy issues that we're encountering that I wanted to put out for possible discussion is that it's important for us to respect the established systems of traditional medicines and the wisdom of these communities. One of the issues that our communities are facing is the misappropriation or the appropriation of traditional knowledges around medicines and the pharmaceutical companies coming in and taking those medicines and making a lot of money off of that. So that's something we can talk about if people are interested. Just would like to highlight that at our Indigenous Wellness Research Institute, this is what we're doing. So some of these priority areas around pandemics, chronic health issues, trauma and wellness, and poverty and structural inequalities are issues that we are committed to looking at. And I'll be happy to address some of those questions. And one of the things I'd like to end with is that in our Native communities, we talk a lot about that the medicine is already with us, that even though we are enduring some of the suffering, we just have to look deeply and quietly, and we have the answers already. It's embedded in our ancestors, it's embedded in our communities, it's embedded in the medicines that remain with us. And then on a good note, a nation is not conquered until the hearts of its women are on the ground, then it is done, no matter how brave its warriors, nor how strong their weapons. Thank you.
Good evening, and thank you for the warm welcome. And it's an honor to be here. I'm a cultural anthropologist, and I study health and healing across cultures, and that makes me a medical anthropologist. And as an anthropologist tonight, the contribution I want to make will be to build on the message that we need a new approach in global health and that we need the political will to be able to make that happen. And as an idealist, I want to emphasize the possibility of a practical, radical vision of hope. And on that note, I wanted to start with just the possibility that one way to improve human health, maternal and child health, everywhere right away would be to stop war as an answer to human conflict. My work tonight focuses on Mozambique and work that I'm doing there and have been doing over the past years. I was there doing in-depth research on barriers to women's use of prenatal care even when it was available and free of charge. And tonight I'm going to focus on women's access to AIDS treatment. But I wanted to make a tie to the wonderful talk that came before me that Karina gave, is that I think working on AIDS in Africa, we're still talking about concepts of historical and contemporary trauma in a real significant way. But let's begin with the problem and the scope of the problem. More than 10% of the world's population lives in sub-Saharan Africa, and yet sub-Saharan Africa bears 64% of the burden of people who are living with AIDS. 90% of the children who are HIV positive live in sub-Saharan Africa, and 95% of the transmission of pediatric HIV, that is children under 15, is due to maternal to child transmission. There are more than 12 million orphans in sub-Saharan Africa, and 75% of all the women living with HIV are in the African continent. Obviously, this creates challenges and possibilities and opportunities. Globally, the AIDS treatment scale-up has been massive and impressive. The number of people who are on antiretroviral therapies in low and middle income countries has nearly doubled in 2005 alone, going from around 730,000 to over 1.3 million who are getting treatment. But if the rates of HIV infection continue, they will far outstrip even this massive and impressive gain. In a place like Mozambique, where there's growing availability of both testing and treatment, many HIV women, and especially pregnant women, drop out of the system before getting onto treatment. This is called loss to follow-up, and it's occurring all over Africa. This slide here, if I can make some sense of it, helps you see how there are several places and moments where we might lose women who could be effectively put onto treatment. Women can get tested in prenatal care. When they come in for prenatal care, if they test positive, they might go to a treatment center where they'll be monitored to look and see if the level of the HIV virus is such that they should begin treatment for themselves. They're monitored and may begin treatment, which is called antiretroviral treatment, which is called HAART in some cases. And then at birth, women can be given a dose, often in poorer countries, it's of nevirapine, to prevent maternal to child transmission. And what we're finding is we're losing women all along the way in this strategy. Let's look at some of those specific problems that we're encountering. Well, we're doing okay. In Mozambique, at least 80% of women are getting some kind of prenatal care. And of those who come in, 75% are getting testing. But then when we get to the proportion of mothers who are receiving nevirapine, it's really low. You can see 25 to 29% only. And of the proportion of mothers, as you could see, who went from testing into treatment and monitoring, it's also really low, only 40%. And of those women who are HIV positive, you see even lower, only 30 are actually starting HAART during pregnancy. My earlier research in Mozambique focused on why women in Mozambique avoided or delayed prenatal care in maternity clinics, despite experiencing some of the highest infant and maternal mortality in the world. If you can imagine, when I was first there in the 1990s, after 20 years of the war of destabilization, women had a 1 in 9 chance of dying from maternal causes. That's changed to about 1 in 14 at this point, and that's a slight improvement. But when you compare it to the UK, where the chance, a woman's lifetime chance of dying of a maternal cause is 1 in 5,100, you can see the desperation of the situation. My earlier research suggested that one of the reasons why women were not going in for prenatal care or avoiding prenatal care was that for women who had the hardest time meeting their basic needs, who had the least control over, and that they and their families had the least control over resources for survival, including food, land, wages, the more afraid women were that the social threats, that is harm caused by individuals with whom they had to compete to survive, from neighbors, bosses, even jealous relatives, that those were the biggest threats to them and their unborn children. So they avoided prenatal clinics to avoid drawing attention to their pregnancies. The most vulnerable women hid their pregnancies as long as they could. So there are lots of hypotheses about why. Why would so-called high-risk women avoid or underutilize reproductive health services? Was it lack of information? Lack of motive, transportation, education, permission from their husbands, social support? Was it religious beliefs or culture? Was there unceasing burden of agricultural or domestic work? Was it the inability to pay, for example, a cash bribe when they went, resulting in ill treatment by staff at the maternity clinics, whose walls, services, and personnel's morals are crumbling under severe cuts to public sector health budgets, under structural adjustment and privatization? My research found that these approaches, all of these hypotheses, avoid a core source of the problem: the economic policies which erode, undermine, and abolish public safety nets, and they're lethal. And that the most vulnerable populations pay the price with their bodies and respond in sometimes unexpected ways. Avoiding prenatal care was an unexpected response. The unexpected part reveals not community pathology, but the lack of inclusion of community input in program policy and development. So what does this experience of prenatal care mean for the conundrum of loss to follow-up among pregnant women in prevention to maternal to child transmission? It suggests that the appropriate questions, solutions, and responses to growing health disparities and the intensifying burden of disease carried by those in the poorest situations are not going to be predominantly behavioral or technological. It suggests that our programs, our efforts, even our focus are focused on changing the wrong cultures. A great deal of the efforts of public health initiatives internationally still focus on changing the behaviors of poor people, and what some people call mistakenly and uncritically the culture of poverty. People who need to keep cleaner, though they have limited access to water, who need to eat better, though they have food insecurity, who need to have safer sex, though the unprotected sex that they have might keep them from living in the streets, who need to pay for condoms so that they'll value them more, though they don't have access to the cash to pay for them, who need to stop having children that they can't afford, though they also have a right to envision a future through children who survive, who need to stop having children they don't want, though the health programs that serve them may not be allowed to discuss abortion or contraception outside of abstinence, who need to be more responsible about getting tested, monitored, or treated for HIV when exposure to HIV-positive status could lose them, their family, and their livelihood. We also tend to place a great amount of focus and resources on the cultures of biomedicine and biotechnology, asking ourselves the question, how can we prevent, manage, and treat a disease like HIV? This focus and this question does lead, in some cases, to better technology. It can lead to better preventive and curative technologies, better specialist knowledge, better health surveillance, more detailed lists of individual risk factors, better clinical services, and access to those who can afford it. In short, less attention gets paid to the context of the AIDS epidemic, that is, global poverty and the cultures of complacence, racism, indifference, greed, and consumption, which are the greatest barriers to social transformation. What shifts if we move from conceptualizing health as the absence of disease in individual bodies to being a product of healthy communities? This shift would lead to greater social investments in a variety of interrelated areas of public life and community life. Large-scale investment in public sector social programs and safety nets to ensure economic survivorship of all communities, from subsidized food, clean, free water, decent housing, universal health care, free health care, education, especially for girls and women, adequate access to land, and toxin-free environment so that people can feed themselves and their children, meaningful work, and protection for laborers, including living wages. This will not immediately solve the problem of loss to follow-up for HIV pregnant women. But the struggle against AIDS will take generations, and we need to begin now in the rebuilding of social programs that will ensure that Africans can fully benefit from access to AIDS treatment. The University of Washington-based governmental organization Health Alliance International has brought together an interdisciplinary, international research, laboratory, public health, clinical, and management team to work collaboratively with the Mozambican Ministry of Health to build infrastructure and human resource capacity to develop, evaluate, and deliver a national AIDS treatment program. The main focus of Health Alliance International is to support the public sector, health system, and help link to community mobilization efforts. We know what works. Let's bring the resources and care and heart to this challenge of the century as global partners, as global neighbors, as global citizens, in a respectful and self-determining and dignifying way. It's not only just, we know it's effective, and we know it's essential. I'm proud to be part of University of Washington's growing work in global health. This is truly a just cause. Thank you.
Thank you very much, and thank you for being here tonight and allowing me this opportunity to talk to you about free trade, intellectual property, and human rights. On March 8th, 2005, about a year and a half ago, thousands of Guatemalans took to the streets to protest their government's ratification of the Central America Free Trade Agreement, which you might know as CAFTA. These mobilizations took place all over Guatemala. This photograph was taken in Guatemala City. And I'd like to call your attention in particular to the jerseys that these women have on. They say, "Mi vida no está en venta." That means, my life is not for sale. That's a pretty strong statement. These women are asserting that the free trade agreement, CAFTA, has put their very lives up on the auction block. As a human rights scholar, I decided to look into that and into the text of the agreement itself. And I asked a number of questions. First of all, why did people perceive that the trade agreement was selling their very lives? Was this true? Was it inevitable? Tonight, I'd like to share just a very brief summary of some of the findings I've come up with and conclude with what I see as the implications of this research for an audience such as this one, committed to the subject of global health. Now, there's a number of big picture ways in which the logic of free trade has implications for global health. One that's often talked about is that free trade agreements typically facilitate the privatization of public services, which can include public health services, and that sparks a lot of concern. Tonight, unfortunately, I don't have time to talk about that, so I won't be speaking about the big picture ways, but rather calling your attention to one very specific to hone in on one very specific area of concern, and that is intellectual property rights and their impact on access to medicines. As you might know, intellectual property law is a body of law which is designed to protect inventors or innovators by ensuring that they receive fair compensation for what they create. Basically, it's all based on the notion that profit incentives should motivate innovation. And I don't disagree with that or have any qualms with it. When we're talking about things like cracking down on counterfeit copies of DVDs being sold on a street corner somewhere, that's one thing. But when we're talking about cutting down on the availability of generic drugs, which are also copies of brand name products, for me that's a very different thing, and it becomes a human rights concern. So how did we get here? Well, just very briefly. In 1994 was when the World Trade Organization was formed, and with it, the TRIPS agreement created for the very first time a single global standard for the protection of IP rights and their enforcement. In the wake of TRIPS, which established for the first time a 20-year patent term, many countries throughout the global south began to express concern that this more aggressive protections for intellectual property rights were impeding their ability to protect the public health of their populations. This led to a great deal of mobilization, especially in developing countries in the WTO, and eventually culminated in the signing of the Doha Declaration in the year 2001. What Doha did was establish 4 important safeguards that would allow countries to administer TRIPS in a flexible way, such that they could confront public health emergencies by invoking things such as compulsory licenses as a way to essentially get around some of the strictures of patent protection in order to provide affordable medication when it was urgently necessary. Since the passage of Doha in 2001, however, the United States government has turned to bilateral trade deals, typically with less powerful countries, to advance a more aggressive intellectual property rights agenda. And the kinds of intellectual property rights that are found in these different free trade agreements vary from agreement to agreement, but they're generally called TRIPS Plus because they go above and beyond what is required under TRIPS. In other words, they require even more aggressive protection for intellectual property rights. As I said, the specific provisions vary from agreement to agreement, but TRIPS Plus provisions can be found in trade agreements with Central America, Singapore, Australia, Chile, Jordan, Morocco, and also the agreements that are still pending ratification dealing with Peru and Colombia. New trade agreements are being negotiated every day. Currently, the United States is negotiating agreements with Korea, Thailand, and Malaysia, which are believed to contain these same provisions as well. So they are very far-reaching in their implications. So what are these TRIPS plus IP provisions? Well, it's a very complicated set of laws, and they're not the same in every single agreement. But to summarize them in sort of a lowest common denominator kind of explanation, there's a number of kinds of laws within this package of TRIPS plus. One set of laws extend the patent term beyond the 20 years established in TRIPS. So now we're contemplating patents that could extend to 23 years, 24 years under some circumstances. That's one thing that they do. Another thing that TRIPS plus laws often do is incorporate mechanisms to ensure test data exclusivity. That's quite a mouthful. But what it means is basically that during a given period of time, and the length of that period varies from agreement to agreement, generic drug manufacturers cannot rely on the test data from brand name manufacturers to show the safety and efficacy of their product. Now, technically speaking, they could administer their own clinical trials to prove that their drugs are safe. But of course, if they were to do that, this would raise the cost of producing their drugs to the point that they would no longer be generic drugs. The bottom line here is that we're talking about longer periods during which only one version of a given drug would be available on the market. That's a monopoly. And any economist can tell you that a monopoly means higher prices for a longer period of time. Why is this worrisome? Well, let me give you an example from a place where I've done research, and that is Guatemala and Central America more generally. In the case of Central America, before the passage of CAFTA, approximately 1 out of every 6 people who needed antiretroviral drugs for the treatment of HIV/AIDS were getting them. So we're facing a situation of scarcity well before the application of these new IP norms that I'm talking about. Look at those numbers. They show that brand name treatment for HIV/AIDS in the case of Guatemala costs 10 times what generic treatment costs. Now that CAFTA is in force, CAFTA won't take existing generic drugs off the market, but what it will do is delay the introduction of new generic drugs. So let me give you a concrete example. There's a new antiretroviral called atazanavir, which was approved by the FDA in 2003. Costs approximately $10,000 per patient per year. At present, there is not a generic version yet available. But if one were developed tomorrow, it wouldn't be allowed to enter the CAFTA countries until 2009, because that drug is currently under test data exclusivity provisions. That means the drug would be available tomorrow, yet not if you happen to live in the CAFTA countries. What this means, to my mind, is that we're denying doctors like Dr. Araton, who you see here in this picture. He's Guatemala's leading HIV/AIDS specialist. We're asking him to fight a burgeoning epidemic while tying one hand effectively behind his back by denying him access to the best drugs. We're also denying people like Edgar here the drugs that he needs to survive to see another day. Edgar is a person living with AIDS who I met in Guatemala. He asked me not to use his last name. He also asked me why my government would pass a law that makes it harder for somebody like him to get access to the drugs he needs to survive. Why, he said, would anybody vote for a law like that? As you might be able to imagine, it was very hard to look him in the eye and come up with a compelling response to that question. But what I said was that I didn't think most people in the United States were aware of these laws. I told him there was a lot of ignorance, and I asked him if there's anything he'd like me to say to people when I had an opportunity such as this to talk to people about these laws. Was there any message he wanted me to relay? And he said, yes, in fact, there is. And so I'd like to quote him. He said, you should not only look at the economic aspect, but also the human aspect of these policies. I couldn't agree more. But at the same time, even if we just limit ourselves to looking at that economic aspect, it's negligible. Central America represents less than 1% of the global market in pharmaceutical products. So what's at stake here, I believe, is precedent. It's not profits. These highly technical and extremely boring laws are effectively rewriting the rule book for globalization in a way that makes health, like so many other things, a commodity for sale for those who can afford it. But what I'm sharing with you tonight is my own analysis. I may be wrong. I hope very much that I am. Much of this is based on projected outcomes. We don't know, for example, how the courts will rule in these cases, and in many countries there's already constitutional challenges lodged in the local courts on these grounds. And even if the courts were to uphold TRIPS plus IP law, we won't begin to feel its effects immediately. That makes it very difficult to measure the impact of these laws, because, as I said previously, these laws don't take existing drugs off of the market, but rather delay the entrance of new drugs to market. So that means its impact is felt in a staggered and gradual fashion. It becomes impossible to measure the impact of such laws within months of their passage. So what I'm sharing with you are some projections, admittedly. Who shares the concerns that I have shared with you? Well, a number of organizations which are deeply committed to global health and human rights. The names of just a few are listed on the screen. And also, I'm proud to say, 13 members of the United States Congress, of whom one is here today, in November 2005, signed a letter expressing precisely these concerns. It's a small number, but I believe it's a growing contingent within our Congress who's waking up to the potential impact of these policies. Yet, of course, every story has two sides, and what would the defenders of TRIPS plus IP provisions say to this critique? Well, in fact, we know because we've put it to them. The US Trade Representative said in response to such critiques about CAFTA, CAFTA expressly states that nothing in the agreement will affect a country's ability to take measures necessary to protect public health. In fact, he's right, that's quite true. But it states this in a side letter, which is not legally enforceable, which means that these amount to noble intentions, but little else. A second argument which you might hear people offer is the argument that, well, actually, free trade agreements increase access to pharmaceutical products by encouraging major pharmaceutical companies to register their drugs in small markets. The idea being that if there's inadequate protection for their IP rights, these companies won't have the incentive to register their drugs in a place like Guatemala or Honduras. That may be true too. But even if that is true, the registering of a pharmaceutical product which is, because of its price, inaccessible to the vast majority of a population, the fact that that drug is simply registered in the market is not the same as ensuring widespread access and an ability to confront the public health challenges that these countries face. Too many of the debates about trade policy in this country are too rancorous. You have people pointing fingers at one another, and it's hard to make head or tails of who's telling you the truth. Given that context and the climate in which these discussions often unfold, I want to be very clear about where I stand. I don't want anybody to think that I'm up here saying that I'm opposed to pharmaceutical companies or anything like that. I believe, in fact, there are many, many problems facing global health today, and we absolutely need pharmaceutical companies to be involved in their solution, just as we need government, just as we need an engaged citizenry. And we also need all the issues on the table. We need not only profit incentives for those who produce new drugs, but also mechanisms to ensure that the drugs we already have reach those who desperately need them. I'd like to conclude by introducing you to Brandon and Jennifer. They are both HIV positive. They were also orphaned by the disease, and I met them a couple of years ago in Guatemala. As our governments write the rules that govern who lives and dies, because let's not kid ourselves, that's what these rules are deciding, I think it's important to remember that it's people like these whose lives are on the line. Wherever you stand politically, whether or not you agree with anything I've said, I think your awareness of these issues and your engagement with them can only help. As residents and citizens of this country, we need to discuss what's being done in our name, and we need to ensure that it reflects the values our nation can be proud of. And I'll leave you with that thought. Thank you.
Hi, it's great to be here. AIDS, malaria, TB, measles, diarrhea, and other diseases kill millions of children and adults around the world. We've heard about inequities that exist among populations within a country and between countries. And, for instance, trade laws actually impact health. What can we begin to do to improve global health? What strategies can we take so that we improve and impact in a favorable way global health? These are questions that I actually asked myself before I got involved in the area of health and human rights. Tonight I will talk about a strategy that I believe is one way we can begin to improve health. And this strategy uses human rights law as a tool to advocate for improved health, especially in vulnerable populations. Now, health is more than health care. The World Health Organization defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease. Health is more than health care. Now, a healthy environment means absence of pollutants in the air and in the water. Likewise, the environment can either be an enabling or disabling one for populations. An enabling environment includes protection of human rights. Populations can be healthy if the environment enables it. Now, this brings me to the law, the right to health. Where do we find this right, and what does it mean? Well, let's start with the 1948 Universal Declaration of Human Rights. Now, this is an aspirational document, and it says that everyone has the right to a standard of living adequate for the health and well-being of himself and of his family, or her family, including food, clothing, housing and medical care, necessary social services, and on and on. The International Covenant on Economic, Social, and Cultural Rights, Article 12.1, states that parties who sign and ratify have the right to the enjoyment of the highest attainable standard of physical and mental health. And this treaty is binding for those countries that sign and ratify. CEDAW is the Women's Convention. It is an international convention that is often described as the International Bill of Rights for Women. Women around the world have had such abuse and discrimination that the UN, in its wisdom, decided in 1979 to adopt it. It defines all the types of discrimination against women, and it actually sets up an agenda for the national action of those countries who sign it to fulfill that obligation and eliminate discrimination of women. It does affirm the reproductive rights of women. By the way, the U.S. did sign this agreement in 1980, but it has not ratified it. Indonesia, in comparison, has signed and ratified this international treaty. CEDAW is formally the Convention on the Elimination of All Forms of Discrimination Against Women. The importance of Indonesia signing and ratifying, and of developing countries other than Indonesia to sign and ratify these international treaties is that they actually, of course, are under international obligations to progressively realize over time these obligations. However, it also provides the countries language that they can then use in their own law. And often, as in Indonesia, they draft national law, which is the most enforceable law. Local law is much more enforceable than in international law. CRC is another very important international right to health law. It's the Convention on the Rights of the Child. Only 2 countries in the world have not ratified the Convention on the Rights of the Child, and you should know that the U.S. is one of them and Somalia is the other. Indonesia, of course, has ratified both. Going to the Health and Human Rights Project that we are implementing in Indonesia, we are using the strategy of human rights as a tool to advocate for better health for vulnerable populations. This advocacy is done with professionals in health and law, and they're advocating together at the local and the national level. Let me say also, for those of you who don't know Indonesia, it's a large archipelago in Southeast Asia of approximately 16,000 islands. Many are not inhabitable. It is the largest Muslim country in the world with approximately 215 million people. The densest part of Indonesia is Java, and it's some of the most densely populated areas in the world. The country is a democracy since 1998, and in terms of health, Indonesia has made incredible progress since the 1960s. However, many Indonesians do not have access to health information and services, and there are many indicators that demonstrate they are unhealthy. There are malnourished children in comparison to Africa, perhaps not as malnourished, but 9.35% of the under 5-year-olds are severely malnourished, and 22% are undernourished. The infant mortality rate is still high at 47. It used to be 145 per 1,000 live births under 12 months. The U.S. is about 6.8 in comparison. Another indicator is the maternal mortality rate. Now, this is a critical indicator of health status of women. The maternal mortality rate at this time is 307. It used to be well over 400. Actually, it was about 450 per 100,000 live births. It is in comparison to the U.S. statistic of 9.8 in 2003. In the U.S., it had been 6 or 7 a few years before that. The Health and Human Rights Project is one that is multidisciplinary and includes health and law professionals. We are targeting professionals to advocate up to the parliament. We are targeting them to advocate for and with grassroots organizations at the local level, since there is decentralization now in Indonesia. Most of the work is actually providing training. The activities include training in medical schools, in public health schools, in law schools, creating curriculum for practicing lawyers, doctors, and public health practitioners and others. We are seeing some early successes. We had a national conference in 2003 that was widely attended. It was attended by people in the government, NGOs, international health organizations, academia, and was opened by the Minister of Health and the Minister of Justice's office. The work we've been doing has been very well supported. The right to health is not as threatening as working in civil and political rights right up front. Although, of course, we're dealing with civil and political rights, the right to life is about the right to health. We did have a conference with the Indonesian Doctors Association, our main partner in health, and they changed their strategy. This is a success. They're now talking about doctors as change agents. The presidential candidates were briefed by the Indonesian Doctors Association, and they were briefed with a paper in 2004, and each candidate got a briefing paper, and the number one issue was the right to health. We also have some education successes in Indonesia at the moment. We see that the first Health and Human Rights course was implemented in the Law School of University of Indonesia. We're working with the Ministry of Education, and we're working with a task force that is reforming the medical education first-year curriculum. They have decided to put a bioethics course and a health and human rights course in the first-year curriculum of all the medical schools in the country. We are working on creating a health and human rights center in Aceh, an area of great conflict over the last few years, and an area that had devastation due to the tsunami. Political changes have occurred. We think we had something to do with this. Perhaps yes, perhaps no. The president and vice president have begun to talk about human rights with that language when they are talking about Indonesia's health. We are now also working with Komnas HAM, which is the Commission on Human Rights, to evaluate the economic, cultural, and social rights in Indonesia. For those of you who want more information, these are the websites at which you can find more information. And I want to thank you very much.
I want to thank all of our presenters for their presentations, for helping us to better understand how we can make a difference by creating a better world for people within and outside the borders of the United States. For the audience, you now have knowledge to make a difference. Thank you for caring and coming.